Hello and welcome. We're filming today at ESMO 22 and joining us, Dr. Hope Rugo. Dr. Rugo, hello.
Hello, thank you for talking today.
Well, you presented the overall survival from the TROPiCS-02 trial at this year's conference. Could you talk us through some of the setup to that and what it means clinically for patients and the whole story of TROPiCS-02?
Absolutely. We were very excited about the overall survival data. TROPiCS-02 is a phase 3 trial that randomized 543 women who had heavily pretreated hormone receptor positive HER2 negative metastatic breast cancer to receive sacituzumab govitecan or chemotherapy of physician choice called TPC. And in that arm, about 48% of the patients received eribulin. Patients randomized in TROPiCS-02 had heavily pretreated disease by study design. So they had to have received at least 2, but not more than 4 lines of chemotherapy for metastatic disease. They also had to have received a CDK4/6 inhibitor, a taxane, in any setting, and at least 1 line of endocrine therapy for metastatic disease. The whole design of TROPiCS-02 is based on 2 different data sets. So one was a phase 1b umbrella trial where patients with hormone receptor positive disease had an impressive response rate in PFS. And then the ASCENT trial, which looked at patients with heavily pretreated triple negative breast cancer and also showed a PFS and OS benefit leading to approval from the regulatory agencies of sacituzumab in patients who'd received at least 1 line of chemotherapy in the metastatic setting. So in this trial, the primary endpoint was progression-free survival by blinded independent central review. 95% of the patients had visceral metastases. The median time from diagnosis of metastatic disease until randomization was 4 years. So these patients already were at the later end of expected survival for metastatic hormone receptor positive disease. Everybody had to have received a CDK4/6 inhibitor, and about 40% had received the CDK4/6 inhibitor for more than 12 months. We looked at first at progression-free survival, and that data was presented at FASCO in 2022 and recently was published in the Journal of Clinical Oncology as a rapid communication. Our statistical design was a hierarchical design, which is very popular these days. So at each step of the way, when you go from your primary endpoint to sequential secondary endpoints, you have to achieve statistical significance to look at the next one. So the trial was powered to find a hazard ratio of 0.7 for PFS. PFS was significantly improved with sacituzumab govitecan with a hazard ratio of 0.66. So it actually exceeded that and then highly statistically significant. The absolute difference in median PFS was 1.5 months, but what we attributed that to was a rapid fall off in the first couple of months where patients with heavily pretreated disease actually have a fairly, a fairly substantial fraction of these patients, about 20%, progress before they even got their first scan in both arms. So Kaplan-Meier is a little bit less useful in terms of looking at medians when you see that. So we looked at the landmark analyses, and at 6, 9, and 12 months, the number of patients who were alive and free from progression was greater in the sacituzumab govitecan arm compared to the treatment of physician choice arm. And at 12 months, 3 times as many patients were free from progression and were alive who received sacituzumab govitecan. So because we saw significance in progression-free survival, we could look at overall survival. The first interim analysis of overall survival was underpowered. The data were not mature. And although there was a numeric trend towards improvement, it was not significant. This second interim analysis, which we presented at ESMO 2022, had 100 more events, so almost 400 events. So it was definitely powered to look for an overall survival benefit, which we did see with a median improvement of 3.2 months, going from 11.2 to 12.4 months in terms of median overall survival. And that was highly statistically significant with a hazard ratio of 0.79. Like progression-free survival, we did a subset analysis, and we saw that all of the major subsets, and including the stratification factors for TROPiCS-02, there was a benefit in overall survival. In fact, the only group where there wasn't a benefit was in the less than 5% of patients who didn't have visceral metastases, a group of patients where the numbers are far too low to make any conclusions. Now, because we saw an improvement in overall survival, we could then look at overall response rate, clinical benefit and duration of response. And all of those were numerically longer, and for overall response, where we could look at statistically significantly greater in patients receiving sacituzumab versus those receiving TPC, or treatment of physician choice. And then because that was significant, we could look at patient-reported outcomes, and we saw a significantly longer time to deterioration in global health status, quality of life, as well as fatigue in patients who received sacituzumab versus treatment of physician choice. And those factors were actually broken out in detail and presented at ESMO 22 in a supportive care, palliative care, oral preferred paper session, also showing benefit in almost all factors, with the exception of diarrhea, which is a known toxicity of sacituzumab and can be managed by antidiarrheal therapies as well as dose reduction. So this is a novel antibody drug conjugate with a TROP2-directed antibody and a topoisomerase toxin that is the active metabolite of irinotecan, with a high drug-to-antibody ratio. And we showed in TROPiCS-02 that we had a statistically significant and clinically meaningful improvement in not just progression-free survival, but also overall survival, which impacts patients with hormone receptor-positive disease in the late-line setting. It's interesting to look at that data in the light of DESTINY-Breast04 that was presented at ASCO and was published in the New England Journal of Medicine in ASCO 2022 and New England Journal the same day. This is another novel antibody drug conjugate that's shown incredible efficacy in HER2-positive metastatic disease. It's a trastuzumab biosimilar, again, linked to a topoisomerase 1 inhibitor, deruxtecan. So a different agent may have different activity in different tumors, and there may not be cross-resistance between these two different ADCs, where you have a different antibody targeting the tumor, and you have, although the toxin is in the same class, they're different toxins. And we've seen in microtubule inhibitors that there could be sequential efficacy. So DB04, DESTINY-Breast04, tested trastuzumab deruxtecan in patients who had HER2-low metastatic breast cancer and was powered to look at the hormone receptor-positive population. There were only 58 patients with triple-negative HER2-low disease, and showed a significant improvement in progression-free and overall survival. And the interesting thing about that study is patients were less heavily pretreated. Although 90% had visceral disease, 70% had received a CDK4/6 inhibitor, and a median of 1 line of chemotherapy in the metastatic setting. And the HER2-low status was centrally confirmed. Interestingly, in TROPiCS, the hormone receptor status was not centrally confirmed, so it was based on the local data. So I think where we've come to with these two really important antibody drug conjugates is that in patients with HER2-low disease in the second-line setting, with now recent regulatory approval, we would use trastuzumab deruxtecan. But in patients who have HER2-0 disease or who've been more heavily pretreated, we will use sacituzumab deruxtecan in this hormone receptor-positive population. And then our next step is to really understand what the efficacy of using these drugs in sequence.
And is there any consideration for using sacituzumab in patients who are less heavily pretreated, and kind of what about the multiple refractory lines of treatment about those patients sets them up most for a response to sacituzumab?
I don't think it does set them up to the response. It was just a mechanism of doing a phase 3 trial with potentially less patients and power to get regulatory approval, and also kind of mimicked the unmet clinical need of the late line setting. So that was the goal of the trial. Now that we've seen efficacy in light of the tremendous success of antibody drug conjugates, the idea is to move the drug into the earlier line setting, and we're hopeful we'll be able to study sacituzumab in the earlier line setting. Certainly trastuzumab deruxtecan is being studied now in the first line setting, and there's a lot of interest in moving these drugs into early stage disease as well, of course, in the right setting and in the right population. How we're evaluating toxicity, which I didn't talk about earlier, is also really important. These drugs have different toxicity profiles, neutropenia being the most common toxicity, diarrhea next for sacituzumab govitecan, again, can be managed with dose reduction and growth factor support and antidiarrheal therapy. And then for trastuzumab deruxtecan, we don't see as much neutropenia, although you can see it, but nausea is the most common toxicity, to a lesser degree diarrhea, although it can be seen. And then the fatal toxicity, potentially fatal toxicity from TDXD is the interstitial lung disease, which occurs somewhere between 12 to 15% of patients. But the rate of grade 5 ILD, which is the fatal grade, has really decreased substantially since we've come to recognize this toxicity, stop drug for grade 1 asymptomatic ground glass opacities on lung imaging, and given steroids and then restarted with clearance. And then for grade 2, we actually stopped permanently. And so I think the important thing about sacituzumab is understanding the risk for neutropenia and prophylactically treating patients so they don't get sick and have risk, particularly if they have diarrhea where you have mucosal damage. And then for patients who are on trastuzumab deruxtecan, managing the nausea up front, giving prophylaxis after the infusion where it can be impact quality of life for patients, and then doing frequent imaging, particularly in the first year of the lungs in patients who have TDXD, so you can capture this ILD early before it becomes symptomatic. So I think, we're getting much better at all of these management strategies, which allows us to move these drugs earlier and earlier into lines of therapy. And I think we've really learned that antibody drug conjugates are a better, more effective way of delivering chemotherapy to cancers, and that the toxicity may, in the long run, be less because we're not seeing this sort of cumulative neuropathy, which is really dose limiting and impacts quality of life so significantly when we give many of our other effective agents in the metastatic setting.
To follow on from the success of the TROPIC study in metastatic and the promise of the Destiny Breast04, there was also the news reported at this year's ESMO conference from the METEORA and ICON trials for metastatic breast cancer that was not quite as successful, but that's also kind of complicated by the data that was reported alongside them. So if we could look at maybe where those went wrong and if there is anything to salvage from them or any new learning that we can take from what has not quite worked in the limited data that they did have, and maybe how that could be worked upon in future trials.
It's a great question, and it's important to keep in mind that the METEORA and the ICON trials were phase 2 trials developed by investigators, and were meant to be signal-finding trials and not definitive studies. So we really wouldn't compare them to these phase 3 registration-like trials with novel agents. But novel agents were used. So in the ICON trial, the idea was that based on very robust preclinical data and some quite nice clinical data as well in the early stage setting, anthracyclines can enhance immune response. And we're continuously looking for ways of turning so-called cold tumors hot. So, making tumors which have a relatively less robust host immune response into tumors that can generate an immune response either by exposing neoantigens or just stimulating the host immune system. So in the earlier stage setting, the anthracyclines do appear to have that effect where you actually increase CD8 positive T cells, et cetera. At this meeting, we saw some very interesting data in the early stage setting as well about some of the factors we should be looking at potentially to understand the host immune response. So in the goal of trying to make these cold tumors hot and get better responses in metastatic disease, which, as you start having more burden of disease and as you get treatment, you actually do two things. One is the tumor itself suppresses the host immune response, and then the treatment suppresses the host immune response. And the tumor starts losing some of the immune factors, tumor infiltrating lymphocytes, PD-L1 expression goes down, et cetera. So in the ICON trial, they looked at the pegylated liposomal doxorubicin along with cyclophosphamide. And it was an interesting way of giving the drug. So they give it at a low dose, 20 milligrams per meter squared, sort of metronomic style. We don't actually know what the optimal dosing or construct, pegylated, is it okay to have it be liposomal or not? And whether or not you should be giving it, if you gave it with metronomic liposomal anthracycline with cyclophosphamide, is that adequate to enhance the host immune response? We just don't know. But in the metastatic setting, using the liposomal formulation allows you to keep giving the drug, whereas you can't, otherwise you're quite limited. So they use that as the backbone. And then in one arm, they just gave chemo. And in the other arm, they gave nivolumab and ipilimumab, the CTLA-4 antagonist. So basically, you're getting a combination. In another study that just looked at giving nivo and ipi together in 17 patients, there were 3 patients who responded. All of those patients got adrenal insufficiency, but it was quite intriguing So the idea was to sort of capitalize on that early data. But what they saw was, irrespective of PD-L1 positivity, which is quite interesting, absolutely no difference in their primary endpoint, progression-free survival. And it was kind of an interesting thing that there was no difference because the PD-L1 positive population was such small in number. And again, we don't really know about that chemo combined, et cetera. So it's an exploratory trial. But the other thing we did see, which we've seen in other studies, is this combination immunotherapy approach caused a lot of toxicity. So you had a lot of immune toxicity with that combo. I think it would have been interesting to look at a PD-L1 positive population and look at their chemo plus nivolumab and then nivolumab plus ipi. You could have even done a 3-arm trial, but of course that was beyond the phase 2 concept. So now we've seen quite a number of trials that have been phase 2 and sort of looked at trying to make cold tumors hot. We're going to see more data coming up in the next 6 to 12 months looking at PARP inhibitors as well. And I think that we haven't quite figured it out yet. This is hard. And in the metastatic setting, maybe it's not the right place to study it. Maybe we need to be looking at how we're improving outcome in patients who don't have an upfront response to immunotherapy in the neoadjuvant setting and trying to alter that approach. Without causing lifelong immune toxicity that can be problematic for our patients. So that was interesting, but again, we need to know more. And maybe we'll talk later about some of the biomarkers in the early stage setting. The METEORA trial was fascinating. So the idea that, if you could give an all oral regimen, then get better outcome, that it would be great. And in the United States, where I'm from, we don't have oral vinorelbine, but it's widely available in the rest of the world. So this looked at oral vinorelbine, cyclophosphamide, and capecitabine. So all oral agents, and capecitabine and methotrexate have been given CM as a metronomic chemo regimen before we had as many effective agents as we have now. And an Italian group did quite a lot of work on that and showed some efficacy, particularly in older women. So this regimen they called VEX. Was compared to IV paclitaxel. And their primary endpoint was time to treatment failure, which is kind of an interesting and odd endpoint. Again, small phase 2 trial. They also looked at progression-free survival. And what they saw was there was a longer time to treatment failure with VEX, the all-oral regimen, versus paclitaxel. And there was a slightly longer progression-free survival. But they looked at overall survival. Again, they weren't powered to look at that. There was no difference. So the sort of take home was, maybe you could get a longer time to treatment failure if you treat it in the first or second line setting with this oral VEX regimen. But it's important to keep in mind that different from what you might think from an all oral regimen where you're giving 3 drugs versus 1 IV, the toxicity was greater and the grade 3 toxicity was greater for VEX compared to IV paclitaxel. Less alopecia, but more grade 3 toxicity, and interestingly, more neutropenia. So you're more grade 3/4 neutropenia. So then you have to use growth factors and hold drug and manage that. So, it's a question. I think, when you have more grade 3 toxicity, maybe it isn't an optimal oral regimen to give for older patients. And we really should stick to, oral CM. But now we have so many other drugs that we can give, including pegylated liposomal doxorubicin, which doesn't really cause cardiac toxicity or hair loss, and you give it once a month. As well as other agents, even metronomic, anthracyclines, vinorelbine, et cetera, that I don't know how much, VEX will be used. I think some, but you have to be very much aware of this toxicity issue. And of course, we don't have oral vinorelbine in the US. So I thought these were interesting trials, really important, to get signals before you do a phase 3 trial. I think it just saves so much in terms of patients who are going to enroll, cost and time to do these kinds of exploratory, but well-powered and well-designed phase 2 trials first.
You mentioned the idea of doing some biomarker analysis and discussing that. Do you see there being much in the way of a future for a general population or a targeted population for some of these exploratory designs that you said with the VEX versus paclitaxel and with the ICON checkpoint blockade combination, like weighing the effect of advancing broad therapies for everyone versus those targeted therapies for a very small patient subgroup out of a very small underpowered trial? Like, are we at risk of getting ahead of ourselves, where there could be advances made with different treatment formulations, different treatment styles, different approaches like antibody-drug conjugates or some, T-cell engager, compared to pursuing a very, very thin thread far too far than our trials are keeping up with?
Well, it's a really good question. And I think that, there are a lot of interesting combinations still to study, different targets within the immune system. TIGIT is one, LAG3, a lot of different, and people now have engineered viruses that don't cause viral infections, but may enhance the immune response, that are injected directly into tumors that are being evaluated. But, it's hard, I think, for companies that are looking at these, because it's a relatively slow and tortured process. And so sometimes they would prefer to, at least get approval through, tumors that are known to be very immunologically active, like melanoma, first. And then if they don't get a win there, they're not going to go into breast cancer, So, these are complicated questions. I think where we've learned a lot is from some interesting work from Northern Europe. There was recently a published paper looking at patients who were treated, young patients who were treated when in northern, I think it was the Netherlands, they had their guidelines said if you had a stage 1 cancer, node negative, triple negative, you didn't get chemo, right? And I think that even if they had slightly larger than 2 centimeter tumors. And so they followed those patients who hadn't gotten any treatment. And the patients who had very high tumor infiltrating lymphocytes actually had a good outcome, not as good as they would with chemo, but a good outcome. It really quite impressive. This is data published in the Journal of Clinical Oncology, and really interesting. And it, suggests that if you selected out patients who had high TILs, that you would be able to find a group of patients who are more likely to respond. But there's another sort of side to that, which is that if you have really high TILs and a stage 1 cancer, you could get chemo and no immunotherapy. You don't have any of the risk of the immunotherapy toxicities. And you have a very high chance on the cost, which is a really important part of it. And then you still have a great outcome because you already know you have these high TILs. The host is already there, ready to fight the cancer with the right, help from chemotherapy. Now, there was an interesting neoadjuvant window of opportunity trial called the Bellini trial from Maureen Koch's group in the Netherlands. And there they looked at sort of a month of immunotherapy to see what happened. But they selected patients who had high TILs to start with. And patients they looked at clinical and radiographic response at 1 month, and then people could go on and get chemotherapy or whatever. And, some people are talking about the fact that in their countries, their regulatory agencies wouldn't even let them do that, where you give a patient with, a lot of triple negative disease, just the immunotherapy for 4 weeks, But in this group of patients with high TILs, I think they argued that they already have a better outcome. But it was interesting. I mean, they saw that a small number of patients actually had, very good responses who had refused chemo and gone to the surgery. 1 patient had no cancer. 2 patients had marked reduction in their cancers. But they also saw that, patients who had these immune markers, including CD8 positive T cells, and really cool spatial study that looked at how close the CD8 positive T cells were to the tumor. And so you can imagine you could have a lot of CD8 T cells, but if they're hanging out there, looking at the grass, it doesn't help. But if they're right next to the tumor, then they're directed to the tumor and they could be much more effective. So this kind of a study is not definitive for treatment, but it could help us identify biomarkers to help us both escalate and de-escalate therapy more effectively. So I think we're going to see a lot more of this moving forward in terms of how we can strategize and individualize therapy. We get a little bit overwhelmed with triple negative disease where we want to do more because we hate the outcome when it's not good. And patients have a short survival when the outcome isn't good. But I think now we're in a situation where we can potentially triage a little bit based on what we understand about the host immune response. And as we're doing these more exploratory studies looking at trying to alter the host immune response in the metastatic setting, I think we do need to move very early, so in the first line setting, and we need to be very careful about the biomarker evaluations, which is tough because biopsying metastatic disease serially is a huge issue for patients, a challenge. We don't get a lot of tumor, it's risky, et cetera. So we're going to need more blood-based biomarkers also to try and understand this better. So at ESMO 2022, long-term data from the so-called DATA trial was presented, and I thought it was interesting. I mean, the trial looked at patients who were postmenopausal at the time of randomization and free of disease, who had received 2 to 3 years of adjuvant tamoxifen, and then randomized them to complete 5 years with anastrozole or go on to essentially 8 years, somewhere in there, 3 more years after 5 years. So whatever you had gotten before. And so basically you're getting 2 to 3 years of anastrozole versus 5 years. And what they showed was really interesting. So although it looked like disease-free survival was better, the statistics weren't, I think the p-value is 0.07, so it wasn't statistically significant. But then they looked at subgroups. And they also looked at overall survival in those subgroups. And their median follow-up now is 10 years. And that's incredibly important for these hormone receptor positive studies to have very long follow-up. So that was very good. And they were able to look at, various risk groups. So they found in their initial forest plots that ER, being both ER and PR positive, seemed to correlate with better outcome in PFS. And EFS. This is early stage disease. So, and then they looked at all the other high risk features that we know increase your risk of recurrence. So they looked at, for example, node positive status and having a higher risk disease. And what they found was that in patients who had high risk disease by all the usual clinical features we use and ER/PR positive, that they had this huge benefit in progression-free survival and a suggestion of a pretty substantial overall survival benefit too. And if you compare that data to what's been presented so far, it is very concordant. So everything we've seen now about extending adjuvant aromatase inhibitor therapy suggests that patients who have high risk, clinically high risk disease by clinical pathologic features seem to benefit from longer duration endocrine therapy. And we have to balance that against the toxicity. There's a couple of genomic tests that have been used to try and understand who will benefit from longer term hormone therapy versus not. And some people use those as well to try and make decisions, like the breast cancer index, but I think that this data is quite good. If you have node positive, grade 3 disease and ER/PR positive, you have a high risk of recurrence after 5 years. And it does appear that extending endocrine therapy, if you've had this sort of sequencing of tamoxifen and anastrozole or an AI, really may improve outcomes. So I thought that was very useful. And it's always good to have data that validates what we're doing in our clinical practices, which I think we all are doing. Small tumor, grade 1, stage 1, doing great. You're not going to extend hormone therapy after 5 years. There is, considerable toxicity from using AIs in women with breast cancer. So we want to be judicious about our recommendations. And in people who don't tolerate the drugs, of course, that may not be a non-starter. And I think we're also really interested in what happens with these newer endocrine therapies. We've seen a really rocky road with the oral SERDs, the selective estrogen receptor downregulators. And one of the studies, EMBER-4, is looking at switching at 5 years to the oral SERD versus continuing with AI or whatever endocrine therapy you're getting. And I think that's another interesting area to look at in terms of tolerance as well. The oral SERDs tend to have more GI toxicity, which may be more controlled and controllable than some of the toxicities associated with AIs.
And lastly, you said there were some interesting notes from the ADAPT trial.
Yeah, so the West German study group has done these amazing, huge trials, ADAPT and now ADAPT cycle, where they're looking at differential treatments based on early response to endocrine therapy. So in the neoadjuvant setting, they give 3 to 4 weeks of endocrine therapy. And if you're postmenopausal, you get, whatever therapy, an AI or tamoxifen. If you're premenopausal, you get physician choice. So you could get TAM, OFS plus TAM, or OFS plus AI, and they do it all at the same time. We tend to think of OFS not kicking in for at least 2 weeks, but they did it all at the same time. And so what they presented actually in both trials was looking at what happened to Ki-67 at 4 weeks and how that impacted outcome. And what they saw actually in the ADAPT cycle trial, they had more women who got OFS in either TAM or AI, and OFS made a big difference on getting drop in Ki-67 to less than 10% in the patients who were premenopausal. I mean, it's very impressive. And also the drop in Ki-67 correlated with better outcome. And so if you get better drop when you're using ovarian function suppression, and your outcome is better, and that helps you triage to different types of therapy. I think that's important. This is still, relatively early on what you should do based on that Ki-67 drop. And there's been a lot of studies that have tried to look at that. I think, a neoadjuvant trial within our own cooperative group, the Alliance with Cynthia Ma, the alternate trial, I think, we just, in postmenopausal women, I think we just don't know. And so there needs to be more data. And as we see the mature results from ADAPT cycle in the future, I think that will give us even more information. Genomic scores like the recurrence score may help us too, because then you could sort of see what the drop is in Ki-67 and look at the recurrence scores and try and better determine what the right therapy is for a particular individual. And I think in that way, we may be able to de-escalate and escalate more effectively. So really interesting data. It takes a little bit of thinking to understand exactly what's going on. But, I think from our exponder, the trial done in the US cooperative groups that looked at using the recurrence score and randomizing to chemo or not with physician choice of endocrine therapy, the most disappointing aspect of that trial was that the majority of premenopausal women with high-risk node-positive disease received tamoxifen alone. And we already have soft and text telling us that ovarian function suppression is important. And here we have another trial which tells us that, that ovarian function suppression is important, along with all the historical data. So that was my general takeaway from that trial.
It seems like it's all culminating towards the very important step of breast cancer being a chronic disease, but certainly not the fatal disease that it once was.
I will say as a breast oncologist, we're not quite ready to jump into the chronic disease terminology. I have a lot of young patients in my clinic who have bad cancer, and they're going to die of their cancer way before they would have had they not had that cancer when they have metastatic disease. So, we're still working on both trying to prevent recurrent disease and also reduce the toxicity, long-term toxicities of therapies. The majority of women who are diagnosed with breast cancer today in the Western world will survive their disease. But breast cancer is still a leading cause of cancer death worldwide because people don't have access to therapy. So there are a lot of different issues which play a role. One just last little tidbit was at the Palliative and Supportive Care Oral Preferred Paper Session at ESMO 22, a German group looked at using compression, so a really tight glove on the hand, versus a cooling glove to try and prevent chemotherapy-induced peripheral neuropathy with taxanes. And it's, again, small phase 2 trial, but randomized prospective study with very nice evaluations, including some imaging. And what they saw was that the degree of neuropathy was the same in patients. And they looked at, a control hand versus a treated hand. It was, they were able to reduce neuropathy to the same degree with cooling and with a compression glove, which was fascinating. Compression gloves, really cheap. You could do it all over the world. So that was very encouraging to me. And that's another area where I think we really do need to be focusing on trying to reduce these long-term toxicities.
I should reallocate my optimism then.
Yes, we're very optimistic. Lots of advances, very exciting year for breast cancer, few years for breast cancer. The data from these antibody drug conjugates in HER2 positive and HER2 negative disease, exciting. Hormone therapy, targeted agents for hormone therapy with the CDK4/6 inhibitors moving into early stage disease and survival improvements in the metastatic setting. There are some, now immunotherapy with improved outcome. So a lot of things to be very enthusiastic about, but it's not quite the chronic disease we want it to be.
Well, thank you so much for your time today.
Thank you.